my name is Sandy Gerosa, and I'm an occupational therapist. An occupational therapist focuses on maximizing a patient's independence in activities of daily living, and that would include bathing, toileting, dressing, and homemaking skills. An occupational therapist is a member of the therapeutic rehabilitation team. Frequently, the rehab team has to employ a variety of devices and equipment in order to improve a patient's physical mobility. Today, I'm going to discuss supportive and positioning equipment, orthosis, and we're going to take a look at a lower extremity prosthetic device. First, let's discuss what the definition of supportive equipment is. Supportive equipment are devices used to help maintain or improve body posture or alignment. Let's now turn our attention to supportive bed equipment. The first piece that we'll be looking at today is a blanket cradle. As you can see, the blankets are suspended with the cradle, and the purpose of the cradle is to help remove the weight of the sheets and blanketing from the feet and ankles of the patient. In a patient that has severely impaired mobility, that is, they have difficulty rolling from side to side or repositioning themselves, even the weight of a tightly tucked under blanket can create problems for heel breakdown and sores because they feel they actually cannot move. I'm going to remove the blankets now and show you the frame of the cradle. This is just one type of blanket cradle. There are others that have brackets that are attached to the mattress, and there's a tension wire that goes over the sides, and over that the blankets are placed to help take away all the weight of the patient's, off the patient's feet. Now we're going to turn our attention to what an A-frame is. An A-frame is a foam rubber wedge used on patients right after a hip replacement surgery. It is held onto the patient with straps that are loosely closed, because if you pull the straps too tightly around the patient, you'll cause more swelling and pain. It's used to help a patient maintain their total hip precautions, and that would mean no crossing of the knees, no trunk flexion, no sitting up past 90 degrees, and no rotation of the hips. Let's now look at some heel supportive equipment. On the patient right now, we have a bunny boot. A bunny boot is held to the feet with a series of Velcro straps. The purpose of the bunny boot is to help prevent heel sores and skin breakdown on the patient that is less mobile. As you can see, this came off in two pieces. It's applied on the wedge in such a manner. It's made with a sheepskin type of material that's very soft and cushioning to the patient. And this particular bunny boot has some lateral supports which prevents the patient's hip from rotating side to side. Often a bunny boot, or as we shall see, a heel suspension boot, is used in harmony with the wedge, because as the patient is immobilized virtually by the wedge, there's a constant pressure put on the heels. So let's turn our attention to a heel suspension boot. It's composed of a complete foam rubber exterior. There's a little supportive pad in here that's adhered to with Velcro, and there's a hole in the boot where the heel is actually suspended and kept off of the mattress. I'm going to put this on our patient. It's actually very comfortable, patients have told me. And this too is held on with a series of Velcro straps. And again, they should not be pulled tightly onto the patient, because this could cause added edema and swelling and pain. It should also be noted that in your immobilized patient, the foot of the bed should be elevated when the patient is in bed in order for the edema to run, swelling to run toward the body. We're now going to take a look at a trapeze. A trapeze is a piece of equipment positioned over the bed that the patient uses their arms to help pull themselves up and reposition themselves, again, when they have severely impaired physical mobility, and rolling side to side is very difficult for them. It's seen most frequently in hospitals, but also frequently with patients that have had a hip replacement. We're now going to look at a couple of pieces of equipment that are used on the wheelchair for positioning. and they would include a variety of bolsters and bedrolls, but for our purposes today we're just going to be discussing two because the number of pieces of equipment for positioning are so vast that we're just going to focus on two of the more commonly used. This is called a lateral support bolster. When it's closed, it makes a round formation with the Velcro, like a bolster would be, and it's used on a patient that has decreased trunk control. That is, they tend to lean one side or another. It's fastened around the wheelchair with the Velcro straps. I have the other one on our helper today already, and it shows that it holds the patient firmly in place. So if they tend to lean one way or another, it'll give them that extra support required. Another thing that we frequently use is a towel roll to make a bolster. You can use one towel, two towels, you could use a blanket roll, and we generally just use mastic tape. Again, if a patient tends to lean from one side to another, instead of the little bolster, if it's more of all of their trunk leaning rather than just the shoulders, this can easily be placed on the leaning side of the patient to help hold them more securely in the wheelchair. At this point, we should also mention that if a patient has moderately or severe trunk control problems, a variety of wheelchairs can be used and will be issued by the therapist. They include names of devices such as ortho chairs, Jerry chairs, high back recliners, and again, this is just a small sampling of bolsters that can be made and used. We're now going to turn our attention to orthosis, but first I'd like to give you a definition of what an orthosis is. An orthosis is a device added to a person's body to support, position, or immobilize a part, to correct deformity, to assist a weak muscle, and restore function, or to modify tone. We're going to be looking at some wheelchair positioning orthotic devices, starting with a hemi-tray. A hemi-tray is made out of a hard plastic material that's easily cleaned and should be kept clean for the patient, PRN, or what that means, as needed, not just reviewed in the morning or when it's taken off of the wheelchair at night, but to be reviewed periodically through the day. Warm soap and water will clean it. There's a bracket underneath that fits into the wheelchair armrest that we're going to slide on right now. And it's used to position the patient's upper extremity. It also helps, little back, there we go, helps increase their trunk control somewhat too. This is used primarily with a patient that has sustained a stroke and has no functional use. That means they have no movement of their upper extremity at all. This is an excellent piece of equipment that we use routinely with stroke patients. We're going to be looking at a second positioning device now, called a trough. It rather resembles a trough. Again, it's easily cleaned and should be kept clean for the patient, and it slides in like manner onto the wheelchair. Before we position a patient's arm into the trough, it should be all the way back to the wheelchair. We'll frequently use a piece of Dyson. It's a tacky back, easily washed piece of material. There is no front or back. And what that does is it holds a towel in place so that the patient's arm will not slide forward, since they have really no control over that arm or active movement. And then the arm can be positioned such. However, in many stroke patients, they run the potential of having a lot of swelling in their arm, and to have it in this flat manner may help their trunk control, will be a good position for their arm, but it does not help with swelling. So very frequently we add a foam rubber wedge. The flat, the back part of the wedge, goes against the back part of the trough. We'll demonstrate that. It just easily fits down, pushes into the trough rather snugly, and also gives some extra elbow cushioning that the towel does not always afford. And it keeps the patient's hand in a functional position that's perfect for the swelling to decrease and go back up into the body. Okay, we can remove this piece, and we're going to next be looking at a commonly used, although very complicated, sling. First, we should say a few things about slings generally, and that's that a sling is used to support a patient's upper extremity or arm. It's used with a variety of diagnoses, included, again, a patient that's had a stroke that has no functional use of their arm. In that case, it would help support their shoulder in the socket, give support to their wrist that generally is in this type of flaccid, we call it, position. There is no control. It's used for patients with dislocated shoulders or rotator cuff tears, or even patients with mild fractures. I brought this sling today because it's probably the most complicated of all the slings that you will see. I'll show you how that goes on. First of all, there's a cuff area. It has a back strap, and that should be your sign that this, you know, is for the elbow. You can go around the back of the patient, one strap in front and one strap in back, and again to the front, one strap in front, one strap in back. The hand is put through, and the wrist and hand are supported, and then a Velcro strap across the two holds it in place. You should always check the back to make sure the straps are positioned appropriately. And now we're going to have our helper stand up and turn around slowly to show you the circle ring position and this proper strap formation for a sling. There's a few general things I'd like to mention regarding slings before we go any further, and that has to do with sling wearing schedules, which can vary. Sometimes the doctor's order will say on when up. That means that when the patient is out of bed, the sling should be on. And the arm is generally positioned on a pillow, and your therapist will tell you how that should be at night when they're in bed. Or the order could read on for ambulation and transfers, which means that's the only time that the patient would require a sling. And very frequently a patient is, when sitting in the wheelchair, will use the trough or the tray when in the chair, and for transfers and ambulation will require a sling. In other events, an order may read that the sling should be on at all times, and that means in bed, in the wheelchair, or when transferring and ambulating. I'd now like to give you a few common tips to remember that are very helpful with all slings. Number one, read the manufacturer's instructions for application. In-servicing and printed materials will be supplied by the occupational or physical therapist. Number two, support the hand and fingers within the sling. Number three, when the sling is properly applied, it should support the elbow and shoulder in good alignment. Number four, straighten clothing inside the sling to prevent pressure areas from sleeves bunching. And number five, check that the sling is positioned properly and does not pull on the patient's neck. Most frequently, directions and illustrations will be posted in a patient's room or in the care plan. We're now going to turn our attention to splints. Splints can be either fabricated from rigid or soft materials. They can be prefabricated from a splint manufacturing company, or fabricated, that means made, molded by one of the therapists, an occupational or physical therapist. Splints also generally have different wearing schedules. Sometimes they'll say on AM, off PM, check 1 or 2 times daily for hygiene, to the splint to be removed and the hand washed. Today we're going to start with looking at a functional hand splint. This is called a stockinette. It's the first piece of equipment that goes on the patient's arm. It acts as a little bit more of a cushioning element and helps decrease skin breakdown. We're going to be applying the functional hand splint, which is a rigid splint. And today I have used a prefabricated splint made by a company, but again, these can be fabricated by therapists. It supports the thumb and all of the digits and the wrist in alignment. It's used on patients that have wrist drop, and I'll show you what wrist drop looks like in a minute. A patient that's had a stroke often presents with no active movement at all of specifically their entire arm, but this is to address the areas of the wrist and fingers and to keep it in alignment. It can also be used on a patient that has tone. That means the hand is starting to get tight. It's difficult for a caregiver to passively open the hand. And this helps to create and maintain that spacing so that the fingers, again, will become more flexible and the patient will not develop a potential for contractures. So that's our functional hand splint. I'm going to remove the Velcro. And I used a variety of Velcro widths here to show you that you will see a variety out there. There is no precise one or two. There's many. And I'm going to remove the stockinette because next we're going to look at a soft splint. This is called a wrist cock-up splint. I'm going to turn it slowly so you can see that there's a series of D-rings, metal D-rings on this type. And as I turn, there's an accordion-like type of fabric material. I'll get my hand out of there and then put it back in so you can see that it expands and contracts. So this will be able to be fit on virtually any patient's hand, but these do run small, medium, and large too, and that's a help. On the back also, which you cannot see, but you can kind of see the coloration is different, is a hard, rigid bar. Once in a while, that bar will slip right through here at where my finger is, and it should be pushed up back in there and anchored. I've seen more than one patient come to therapy with the bar sticking partially out. It's adhered to the arm with a series of Velcro closures, so we're going to show that now. This is a good indication to talk about not pulling on the Velcro straps, because what you're going to do then is create skin breakdown and pain for the patient. The splints, whether they be rigid or soft, serve the purpose of the functional placement and holding of the hand. All that the straps do is merely hold it on. There's no reason for this type of pressure to be applied, just very gently, just to fit that patient's contour of his or her body. And then we can raise it up. Generally, this is a brand new splint. These would be all rounded off, so there's no sharp edges by the therapist. Often the rigid and the soft splints are labeled on days, off nights, on days, and for what hand they're for, as well as directions being put in the care plan for you. And in-servicing, lots of in-servicing by your therapist. One last word about splints, and probably one of the most important of all, is splint precautions. If there are any signs of redness, pain, swelling, or skin breakdown, the splint, whatever type it is, should be removed immediately. And the nurses or your therapy department should be contacted, and the splint should not be reapplied until they are contacted and the problem is solved, which often means that there'll be a refabrication or a changing of the splint, or maybe an entirely different splint may be required. So it's very important that you do thorough skin inspections, not only in the morning or in the evening when the splint is applied, but throughout the course of the day, removing the splints for hand washing and hygiene. It's very important that all materials are maintained in immaculate order and that all the skin is inspected thoroughly. Even perspiration, as I briefly mentioned before, can create a hot, damp, moist environment where pressure areas can start becoming broken down and very painful to the patient. Let's now turn our attention to palm guards and washcloth rolls. First, I'd like to say a word about washcloth rolls and tight, contracted hands. By contracted hands, I mean that tight fist that you'll frequently see patients in long-term care that they've developed over years. In fact, I've seen several where the nails have actually embedded into the skin. And as a result, nursing, by trying to help with this problem, and therapy too in the past, has used a washcloth in the palm of a patient's hand. But now it's felt the washcloth, because of its texture and the softness of the material, actually increased more contracture or tighter fisting to happen. So traditionally now palm guards are used. It's made out of a lamb's wool-like type of material. It's affixed with a Velcro strap. There is a hole in the side for the thumb, and it's usually very, very soft for the patient, and they find that it's very comforting. Again, it can be worn in the day or the night. My personal feeling is that if a patient has any functional use of their hand, even if it's just a small pinch, that any of the palm guards should be left off in the day so that the patient can actually use the little mobility they have in a functional way to help wash their face, maybe pick up washcloths, help with feeding. So frequently you'll see these just on at night if there's any use at all of the hand. I'm going to put this on now. And again, the strap would be rounded so that it could not cut the patient, and it would be shortened quite a bit. Palm guards can also be washed, even in a machine, with soap and water, warm and dried, so they can be sent down to your laundry department. Let's now proceed to cones. Cones have been used for many years in especially long-term care facilities. What should be remembered about a cone, and this one has a soft strap to hold it onto the back of the hand, is that the large end of the cone should always be placed where the little finger is. And that's traditionally how a patient that has some tighter fisting would utilize the cone in order to increase the size and dimension of the grip. When a patient starts developing contractures or fisting, it's very, very painful. Then when the hand is trying to be forced open to wash it, it's very, very painful. That's why a variety of splints, both soft and rigid, are used in therapy departments for the patients. We should talk a little bit about splint care on a rigid splint, which for our purposes today include the functional hand and the cone. They should be washed with warm, soft washcloth, warm water, and soap, not hot, because a lot of the materials these splints are made out of will melt if hot water is used. The straps should be kept dry. The stockinette, which I showed you initially, should be washed out every day, because even though you may not see food stains, there's perspiration that results, and these dry overnight or in the day if the patient has a wearing schedule as such. It'll dry very quickly. Everything must be kept clean. The wrist cock-up splints can be washed by hand in warm water, and these will dry within about a 12-hour period as well. Everything on your patients, everything we've even spoken of today, must be kept in immaculate order, as you would want for any of your own family. We're now going to look at a lower extremity orthosis called an ankle-foot orthosis, or more commonly referred to as an AFO. An AFO is used on a patient, frequently that has had a stroke again, that has no control over their ankle or their foot in any way. And the AFO gives them the support that they need in order to start standing balance and ambulation training. It's made out of a hard plastic type of material, and there's Velcro, again, closures. These can come in prefabricated from a company, or they can be fabricated by primarily a physical therapist. Before the AFO is even put on a patient's foot, the foot should be inspected to see if the AFO from the previous day has created any skin breakdowns, sore, or painful areas. How it's put on is first it's inserted into the patient's shoe. Then the back of the AFO, because of its smoothness, actually acts as a sort of a long-handled shoehorn, which greatly assists in putting it on a flaccid leg, which means a leg with no control. Then you can lift the patient's leg back, push down on the knee, and it goes right in. Frequently, an elastic shoelace is used at this point, too, if we are training a patient on how to put it on and off themselves. There is the strap, the Velcro strap, which would go around and attach to the ankle and at the upper part of the calf in order to secure it. And it gives the patient, again, that balance where they could stand and start ambulating, where before they had absolutely no control, and you'd see them stand and the ankle would be rolling and there'd be absolutely no support. It's used routinely in therapy. Shortly, we'll be looking at a lower extremity prosthetic limb. When a patient has undergone the surgical removal of a lower extremity, we refer to this as an above-knee or below-knee amputation. The immediate concerns after surgery, of course, are wound care, ACE bandaging, and the use of a residual limb, or that portion of a patient's leg that's remaining, a shrinker on that area. Once the edema or swelling of the leg has subsided, the doctor will send an order for a prosthetist to be consulted to fabricate a lower extremity prosthetic limb. So let's turn our attention to our above-knee amputee device. It has a harness which helps secure it to the body of a patient. The concern of the caregiver primarily will be in this segment of the prosthetic limb, which is called the socket. I'm going to turn this around and tip it so you can get a look at the hollowness of the inside. And this is the part of the limb that the residual limb is inserted in. What should be kept in mind is that, before we go any further, is that this part of the prosthesis must be kept clean and wiped out every day inside with mild soap and water, so that nothing but only the cleanest materials touch the patient. Inside of the limb, before the limb is inserted into the prosthetic leg, there can be several types of application materials. There can be sheaths, which are made out of a nylon type of fabric, which resemble actually the bottom of a pair of nylons, and they can be of different plies or densities. Over that is generally placed a sock, which is more whitish in color generally and is of a cotton nylon blend. So you'll have your sheaths, you'll have your sock, and then the residual limb would be inserted into the prosthetic leg. However, recently I've seen some gel type socks used, and that would be put on the patient's residual limb, and then the limb would be inserted again into the socket. The points that should be remembered here are that all the gel type sheaths, the sheaths themselves, and the sock must be kept very clean. They have to be washed out every night by hand and absolutely be dry before they're put on the patient's skin. Also, the patient's skin must be inspected all the time, especially in the beginning when they're trying to build up a wearing tolerance to the lower extremity prosthesis, because it just doesn't come when the leg comes. Therapy, specifically the physical therapist, is working on the wearing tolerance of the prosthetic leg with the patient, and that can start with as short as a few minutes, building up to 15 minutes, a half hour. Every patient is individual. What the caregiver's concern is to be sure that they're following the guidelines for wearing tolerance and to keep the leg and the materials used on the residual limb and the residual limb itself as clean as possible. If there's even a tiny pinpoint segment of the residual limb that looks as though there's any redness starting, swelling, anything unusual at all, it should be reported immediately to nursing in the therapy department, and the prosthesis should not be put on the patient until all these concerns are reviewed by the appropriate medical personnel, and even the prosthetist will be contacted, and he may come out and see if there's any changes he can make to help rectify any problems. There are some guidelines that follow all orthotics and prosthetics, and I'd like to review those with you. Number 1, the caregiver checks skin condition for irritation prior to applying the device. Number 2, the caregiver examines prosthesis or orthosis for condition and cleanliness. 3, notifies the therapist or nurse when any broken or loose parts are evident, or comments from the client indicates that the fit is not comfortable. Next, allows the client to assist as he's able. Next, asks the client about comfortable positioning of the device. Checks for pressure where the device attaches to skin surfaces if it were in contact with the skin. And lastly, handles the device in a way that minimizes damage. I want to thank you for having me here today to discuss supportive and positioning equipment, orthotics, and prosthesis. Again, remember, there's a vast array of equipment and devices out there, and for our purposes today, we just focused on some of the more generally commonly used items. But most importantly, I want you to remember the most important rule of all, and that's to treat all of your patients as though they were your own family members. And thank you.